But right now, we're going to have our second presentation, a cardiology presentation from Dr. Jose Nativi from Huntsman in Utah. And Dr. Nativi, are you there and ready to take it away? You're on mute. I see you. I think you're muted, though. There you go.
Yes. Can you hear me?
Yes.
Yeah, I'm going to start sharing. Okay. So can you see my slides?
Yes, we can.
Well, good morning and good afternoon, everybody. Thank you for the invitation. I think this is the largest video conference that I have participated. So very excited to be here with everybody, and a lot of friends are here, and a lot of patients. As Muriel mentioned, kind of sad that we're not going to be able to meet in person this year. The support group is something that is our highlight event of the year. We host around 100 patients and families every year, and it's a lot of fun and a lot of interaction. So now we're moving to the online version of the support group. So I think it's going to be a new way to do it, and I hope that you enjoy it. So I was asked today to review how light chain amyloidosis affects the heart. So the majority of my talk is going to be predominantly about light chain amyloidosis. And if someone has some questions about TTR amyloidosis, or there's any confusions about it, we can talk about that on the questions. But I'm going to focus predominantly on light chain amyloidosis in the heart. These are my disclosures. And we're going to divide this topic in a couple of questions about how does amyloidosis affect my heart if I have amyloidosis? What are the symptoms of amyloidosis in the heart? How do I know if it is affected, either with imaging modalities or laboratories? And just one slide at the end about what else we can do on top of the robust strategies described by Dr. Dispensieri. So again, we're going to focus on the top light chain amyloidosis. These are the two most common clinical types of amyloidosis, but there are other types, and both of them share the same end pathway, that is an amyloid deposition of this insoluble fibril. And the problem starts here in the bone marrow with an overproduction of these cells that we call plasma cells, and they have an overproduction of these light chains that misfold and transforms into amyloidosis fibrils. And when this amyloid deposits on the heart, it causes destruction on the muscle tissue. You can see here, this is a tissue from a heart biopsy. So you can see a normal structure here of the heart cells joining together to produce contraction and relaxation. But when patients have light chain amyloidosis and you see the same tissue under the microscope, now you see this light pink substance that is insoluble, and this is amyloidosis. And you can see how it caused significant destruction of the heart tissue compared to a normal one in the top. But patients with light chain amyloidosis, and this is common for both light chain amyloidosis and TTR amyloidosis, transthyretin. But patients with light chain amyloidosis, unfortunately, they also have the heart muscle affected by this light change that they have not deposited yet. They have not, they have not transformed yet into amyloidosis. They can also affect the heart, and they are cardiotoxic in the heart. So as you can see, this muscle is affected by two significant ways. One is this amyloid infiltrate, but also the circulating light chains are toxic to the heart tissue. So that's why it's very important, as Dr. Dispensieri mentioned, to remove this light change as soon as possible from circulation to avoid this light change to cause more cardiotoxicity in the heart. So this is how amyloidosis looks on the heart tissue. So how does they affect the heart? Well, the heart has several functions, and it has the heart muscle, and that can be affected by amyloidosis. It also has an electrical system. That is, the electrical system is what triggers the contractility of the heart, and this can also be affected by amyloidosis. And in some patients, not all of them, also these vessels that are, you can see here on top of the heart, we call these vessels coronaries. And these are the vessels that supply the blood flow to the heart. In some patients, these vessels can also be affected by amyloidosis. So now let's expand a little bit more in terms about amyloidosis affecting each of these three aspects of the cardiac or the heart function. So let's go back and focus on the muscle. We're going to spend some time here talking about the muscle. And if you can see on the diagram to the left, you can see a normal heart with the right ventricle and the left ventricle. Those are the chambers at the bottom, and then we have the atriums that are the chambers, smaller chambers at the top. And you can see in the right, when there's amyloid deposition, you can see that the walls of the ventricles become thick. And that's one of the features of this condition. The heart becomes thick, your heart becomes thicker, but it's not from muscle, actually. It becomes thicker because of amyloidosis, amyloidosis depositing. It can also deposit in the valves. The heart has some valves that control the direction of the blood flow. These valves can also become thick from the amyloidosis deposition. If the heart becomes thick, one of the aftermaths is that the heart has difficulties now with relaxation. It becomes very, very stiff, and the heart, in order to have a normal function, should contract and relax, But in amyloidosis, this amyloidosis deposition, the heart has difficulties relaxing. Your doctors might mention something about diastolic dysfunction. That's the fancy way to call it. But what it means is that your heart is not relaxing enough. And with time, the heart also, the muscle of the heart can also become weak. And the way that your cardiologists measure the contractility of the heart, there's several ways to do it. And strain is one measure, but the one that is used around all the cardiologists around the world is called the ejection fraction. And the ejection fraction is a measure of how efficient is the contractility of your heart. And a normal contractility at rest is around 52 to 60, sometimes 70%. And then with exercise, it goes higher. but this is what is normal. So bottom line, having these amyloidosis fibrils affecting the muscle structure, it causes thick ventricles, stiff ventricles, and can also cause weak ventricles. And we're going to talk later about how does that feel in terms of your symptoms. The amyloidosis can also affect the electrical system of the heart. So as you can see on the first figure to the left, the electrical system of the heart should produce an impulse from the top chambers and go to the lower chambers. But when there's amyloid affecting these upper chambers of the heart, there's multiple erratic impulses. Instead of being one at the same time, there's now multiple electrical impulses at the same time. And now your heart gets out of sync. Instead of having a regular contractility, now it has irregular contractility. And we call this atrial fibrillation or atrial flutter. And that's because the amyloid also affects the upper chambers of the heart, the atrium. Another way that the amyloids can affect the heart, you see this area here on the middle of the heart that is dividing the right and the left ventricle. We call this the septum or the septal wall. This wall is predominantly one of the most one that is predominantly affected by amyloidosis. And if you have this area full of amyloidosis, there's going to be problems of the electrical impulses coming from the top to the bottom. So that we call that either conduction delays, that's the medical term, but basically what it means is that the electrical impulses from the top are struggling to go to the bottom because now they are facing these amyloidosis fibrils, and it can cause slow pulses. So a normal pulse is around 60 to 90. So now your pulses are going to go to 40s or 30s, and they can also have pauses, meaning that when you have a pause, that means that the bottom chambers of the heart are not receiving any electrical impulse for some period of time. And that could be dangerous because you can pause and you can faint if there's no electrical conduction that can trigger the contractility of the bottom chambers. So that's why some of you on this meeting have pacemakers, is because this amyloid depositing on the septal wall of the heart is not allowing electrical conduction to go through. And what does the pacemaker does is that it gives that electrical impulse artificially, electronically, that your amyloidosis is blocking. Now the pacemakers can give you that electrical impulse, and in that way your heart can contract. This is something that Muriel asked me to explain briefly about the treatment for atrial fibrillation and atrial flutter. That is a common problem in patients with amyloidosis. First, and the most important thing is anticoagulation blood thinners, because when the patient is on atrial fibrillation, these chambers here at the top, they don't have a good contractility. So there's formation of clots in these chambers. And these clots can go to the brain and cause a stroke. So that's one of the major dangers of atrial fibrillation. So you need to be on blood thinners, and your cardiologist can discuss with you what type of anticoagulation. When the rhythm goes too fast and your pulse, instead of going in a normal 80 beats per minute, now goes to 120, 140, 160 beats per minute, you can get short of breath, you can pass out. So we need to try to slow that pulse. And there's some medications that we can use for that. The most commons are, there's plenty of them, but the most commons are metoprolol. Some of you are on metoprolol, or you are on amiodarone. Make sure that none of you are in diltiazem. And if you are in diltiazem, please make sure that your cardiologist knows that you have amyloidosis, because diltiazem can cause serious problems because it binds to the amyloidosis and becomes toxic on the heart. So remember this name and make sure that you are not on that medication. And then there's another way to treat atrial fibrillation that is with rhythm control, that is going back to removing those erratic impulses here on the upper chambers and just try to give normal pace rhythms. There's a couple of ways to do that. And one way is with medications. Amiodarone is one of the most common, but there's others in the market. We can do cardioversions. Some of you have had cardioversions when you go into sedation and we shock your heart, kind of put a stop. Basically, what it causes is a pause in all of these erratic electrical impulses, and then the heart starts bringing their electrical impulses normally by itself. Sometimes that doesn't work or comes back, so we do ablations. An ablation means that you go to the cardiac catheterization laboratory. We put some catheters from your neck, catheters from your legs, and then we go inside the heart. And then when we are inside the heart, we go to the upper chambers and we try to do some burning and causing some scars that are going to cause a block. We're trying to isolate those erratic electrical impulses to go to the bottom chambers of the heart. So we're trying to isolate that with electrical currents that will cause some scars. An A-flutter is very successful. If you have atrial flutter, the success rate of an A-flutter ablation is more than 90%. On atrial fibrillation is not that the success rate goes anything from 60% to 90%, and sometimes patients require 2 or 3 of those. And then when patients are going to surgery, either for a valve replacement or for bypass surgery, sometimes we can do this, the same concept of the catheter ablation. We can do it by surgery and try to do some surgical electrical scars on the upper chambers of the heart and try to isolate those electrical currents. And that requires an operation room, that requires a surgeon. It's not that common. It's usually offered to patients that have failed all the other 3 mechanisms, and especially if they're going to already open heart surgery for other causes. And then the last way that we talk how amyloidosis can affect the heart is causing some deposition in these vessels that we call coronaries. So the coronaries are these vessels that are on top of the heart, and they give blood flow to the heart muscle. And when there's any blockage here in this flow, the most common reason to have blockages is cholesterol disease, and usually cholesterol deposits when there are risk factors like tobacco, obesity, diabetes. And if there's an acute blockage here, that's when patients have heart attack. And the area that is not getting blood flow, that produces a lot of chest pain. And then the patient have to go emergently to the cath lab. In patients with amyloidosis, they could have a similar deposition, similar to cholesterol. They can also have a similar deposition of these amyloid on these vessels. Again, it's not that common compared to how amyloidosis affect the muscle and the electrical system, but in few patients we have seen this phenomenon, and is repaired with, we go with cardiac catheters, we inflate and dilate that stenosis with balloons, and then we put a stent. But not the most common type of presentation. So how I'm going to feel when amyloidosis? As we know, light chain amyloidosis is a systemic disease, meaning that it can affect almost all the organs in your body. Predominantly on the heart causes heart failure, and we're going to expand on this, atrial fibrillation. The kidneys can cause losing protein in your urine, and it can also affect your autonomic nervous system, causing lightheadedness when you stand up, or chronic diarrhea, weight loss. These features that are common in some books about this changing in the color of your eyelids after sneezing, or other types of stressors, or the big tongue, they are not that common in light chain amyloidosis. It only happens in around 15% of the patients with light chain amyloidosis. But if a patient doesn't have a diagnosis and they show with this, it's very suggestive that the patient have light chain amyloidosis. But we're going to focus on the heart symptoms for this lecture. And when the amyloid deposits on the heart muscle, as we remember, the heart becomes stiff, it doesn't contract, and also becomes weak. So the most common symptoms are going to be shortness of breath, predominantly when you try to walk. It can also happen when you're watching TV, but it's predominantly when you start to walk up. Also causes a lot of fatigue. This fatigue is out of proportion to other patients with heart failure, because the mechanism of fatigue in amyloidosis is multifactorial. It's the problems with the muscle, but also patients with amyloidosis, when they try to walk, their pulse, their heart pulse doesn't go as fast as it's supposed to go. Also, when you walk, there should be some changes in your blood pressure, and patients with amyloidosis also have those blood pressure problems too. So your fatigue is a combination of a heart being affected and your heart not being able to generate a pulse and a blood pressure when you try to walk. So this fatigue is very, very pronounced in some patients with amyloidosis. As the heart becomes stiff and weak, what happens is that the body starts retaining fluid. And when it retains fluid, that fluid goes to your lungs and you're short of breath. It also goes to the rest of your body, to your abdomen. It goes into your extremities. And predominantly, when it affects the heart, the patient will have weight gain. But amyloidosis is complex. And some of you, your first years with amyloidosis, you were having weight loss, even though your heart was affected. And that's because amyloidosis, on top of affecting your heart, was also affecting your gastrointestinal system, and maybe you show up with weight loss. But for sure, weight gain is a serious concern that your heart is struggling to work efficiently. So this is something that we stress in our patients and this is something that all of you should be doing, tracking your weight. As soon as you notice a 5 pounds weight gain, you should tell your providers about it. Don't wait for the next appointment. Don't wait for the next chemo session. Don't wait to show up with 10 pounds, 20 pounds of weight gain, because it might be too late to remove the fluid, and then we might need to admit you to the hospital. So place close attention to your weight changes. Try to put it on a book, bring it to your doctors, and especially if you notice a weight change, please let us know so that we can take care of you. There's a couple of things that we can do by the phone in terms of weight gain. If the electrical system is affected, we talk about this. You have fast pulses, either from atrial fibrillation, atrial flutter. You can feel extra beats, kind of palpitation, fluttering in your chest. You can notice or feel like your pulse is faster, or you can become lightheaded now because your pulse is too fast. On the other hand, if your electrical system is too low and your pulse is going too low, you might also have faints or passing out. But either way, if your pulse is too fast or too low, you can faint and pass out. So those are the major symptoms for patients with amyloidosis. And as I mentioned before, the chest pain is not a common feature but it's an important one if you have chest pain, something to notify to your cardiologist. So how do I know if my heart is affected? This is the classic one. This is the most common. I think that almost all of you have had an echocardiogram, and you remember when someone did this to you, and most of you have this every 6 months, every 12 months, or just once a year. Basically what we're trying to look for a lot of things, but to keep it simple, these are the views that this is how the heart muscle looks on an ultrasound of the heart on an echocardiogram. You can see the images here, and you can see these walls of the ventricles. You can see them very nicely. This is in a long axis on the left, and on the right, this is what we call a short axis. That is a heart muscle that is cut through the middle for that view. And you can see here a patient with amyloidosis. You can see in the long axis views at the top, how thick is this ventricle? A normal thickness on this ventricle should be around 1 centimeter. And you can see in this patient is 1.8 centimeters at the top and 1.7 at the bottom. So very thick ventricles. This is something that your cardiologists are going to be looking. How thick is your ventricle? And this is how it looks. Here in the short axis, you can see how thick it looks like a donut. You see how thick it is. It's more than 1 centimeter thick. That's not normal. Also, all of you remember, I guarantee you, all of you have had this EKG. Basically, what we're looking is for the electrical system. You remember we talk about atrial fibrillation, atrial flutters, slow pulses, pauses. This is what your cardiologists are looking. When they do an EKG, this is what they want to know. If you have atrial fibrillation, atrial flutter, slow pulses, or pauses. On top of that, we look for other things like that are specific for amyloidosis, something that we call low voltage, meaning that the electrical activity on patients with amyloidosis, the electrical impulses are shorter compared to a normal heart, because now that electrical impulse, instead of going through muscle, is going through amyloidosis. But that's something that they look at it, but predominantly is to see if you have any complication from the amyloidosis. MRIs is another way to explore if there's amyloid on the heart, and this is how it's gonna look on the MRI. A normal heart, you can see in this view, should look like a donut, should look black. And you can see some white here on the middle of that donut. That's amyloidosis. And there are several patterns that your doctors are looking at it, but that's what, when they do an MRI, this is what they're looking to see if that donut is black, meaning that the muscle is free and the muscle is free of amyloidosis. But if they see white where the muscle should be, that's the presence of amyloidosis. Some of you had pyrophosphate scans, and this is measures uptakes of the amyloidosis. This can be positive in patients both with light chain or TTR amyloidosis, but the clinical utility is predominantly for patients with for TTR amyloidosis. So this is not a test that is going to be is not going to be commonly offered to patients with light chain amyloidosis. Moving to the blood tests, some of you have heard and remember about the BNP or the NT-proBNP. So what happens is, as you can see, if you can compare a normal heart and a patient with amyloidosis, when the heart becomes thick from amyloidosis, the pressures inside the heart becomes very high. And when the pressures becomes high, there's a wall stress on the ventricle, and that wall stress releases these biomarkers that we call BNP and NT-proBNP. Excuse me. And they are very useful in patients that presents with shortness of breath. Like the most common way to use it is a patient comes with shortness of breath to the emergency department. We do a BNP or an NT-proBNP. And if it is normal, that means that this shortness of breath is not from the heart. probably is going to be from the lungs, from asthma, COPD, or something. But if the patient comes short of breath, you are not totally sure what is causing the short of breath, you measure the NT-proBNP and it's high, then that suggests that that heart is struggling. In patients with amyloidosis, these markers are even higher because the wall stress is higher in patients with amyloidosis. And we just need to be careful when we interpret these labs because they can also be elevated in patients with kidney failure and patients with atrial fibrillation. So these are the normal values. A BNP should be less than 100 and an NT-proBNP should be less than 125 if you are 75 years old, or if you are more than 75, should be less than 450. But this is for normal population. In patients with amyloidosis, by default, and if you have cardiac involvement, your levels are going to be higher than this. Your levels are going to be 500, maybe 1,000. So it's a matter to, you don't want it, it's very hard to get you back to normal as soon as you have the amyloid deposition. But what you want to track is if it is going up or if it is going lower compared to your initial NT-proBNP. So when you already have amyloidosis, you don't follow these normal values. Basically, you follow your value, the value that your doctor gave you, and then you can compare if it is getting better or worse. Same with troponins. It's another biomarker that is released from the muscle, heart muscle, but this biomarker is released when there's muscle injury. And there are several reasons to have muscle injury. Heart attacks can cause elevated troponins. Patients with heart failure can have elevated troponins. And amyloidosis, we talk about this amyloid affecting the muscle structure and also the light change being cardiotoxic. All of those things will cause elevated troponins. So this is another blood test that your doctors are going to be checking to see how much damage is happening to your heart. Heart biopsies, the gold standard. Probably some of you have had heart biopsies. It's not indicated for everybody. Not everybody with light chain amyloidosis require a heart biopsy. Sometimes with a fat pad biopsy or a kidney biopsy or a bone marrow biopsy and an MRI, maybe that's enough to confirm that you have amyloidosis on the heart. But sometimes when the diagnosis is still undergoing, some patients might require heart biopsy, invasive procedure of the heart, but it's the gold standard to diagnose it. And this is how it looks, the tissue, when we look it under the microscope. This is the initial stains where I show you the destruction of the amyloid, destroying that muscle tissue. This is how we see it. Some of you remember reading about Congo red, polarized white, apple green birefringence. This is how it looks on the microscope. And then we confirm that it's light chain amyloidosis under mass spectrometry. And this is very short. My last slide. We're done. Patients with AL amyloidosis with cardiac involvement, as we discussed, the therapy, standard therapies, chemotherapy, with or without stem cell transplantation. But in some patients might have hearts that are too weak to undergo stem cell transplantation. So some people might get heart transplants before stem cell transplantation. Other patients might get heart transplant after stem cell transplantation. But this is not something that is offered or that everybody meets criteria for that. Just selected patients who are struggling a lot from heart failure can undergo heart transplantation. And with this, I will finish my lecture. Just want to say thanks to my team, and thank you to everybody for joining us today.
Thank you so much, Dr. Nativi. That was really helpful, and you answered a lot of questions. And like Dr. DeCenzieri, you probably generated a few questions as well. And I'm very proud of our doctors being able to answer a lot of questions that have been typed in on the Q&A section. So that's really wonderful.